All right, good evening, everybody, and welcome to the second part of our web series. Today's topic is mastering full arch implant restorations, removable overdentures with Dr. Christopher Resnik. My name is Robert Milad, and I will be your host for tonight. I'm with ITX Pros, and just to give you a little background on ITX Pros, we are a digital dentistry lab providing turnkey solutions for your implant cases with treatment plans, surgical guides, all on ITX cases, as well as radiological interpretations. We are a full service provider. We have dentists and engineers that are continuously and accurately working on your cases. We have facilities all across the United States with our headquarters based in Delaware, our manufacturing facilities in Oklahoma, as well as in Tampa, Florida. So welcome, everybody. I'd like to introduce our speaker tonight, Dr. Christopher Resnik. Dr. Christopher Resnik is a prosthodontist who is at private practice in Winter Park, Florida. He is also a faculty member at the Mish Resnik Implant Institute, as well as in faculty at the Resnik Implants Hands-On Bootcamp. I know I've mentioned this before, but if you haven't done the bootcamp, it is a must-attend course. So with that, I'd like to hand it over to Dr. Christopher Resnik. Thank you for joining.
Robert. Thank you, Robert. Appreciate it. First, to just go through everybody that we have on the panel tonight that will be answering questions throughout. That was Robert. He is the CAO of ITX Pros. We also have on AK. He is the CEO of ITX Pros, and he will be talking at the very end about some of the promotions. We also have on Dr. Hussein and Dr. Sarah, both dentists that work for ITX, the CCO and clinical director. On it from the Mish Resnik faculty, we have Tara Resnik, Rick Robinette, and Amanda Sheehan that will be answering questions throughout the webinar tonight. So with that being said, we'll get into it. Tonight's webinar agenda is going to be dealing with the edentulous arch, specifically removable treatment planning and execution. We're first going to be talking about some of the issues we have with overdentures on the maxilla and mandible. We'll then go into the biomechanics of implant overdentures, as well as ideal implant positioning for successful implant overdentures. We'll then briefly talk about the bar, doing splinted restorations versus independent attachments for overdentures. We'll go over a couple different types of overdentures, and then we'll finish with some troubleshooting, some common complications that you may have in your office with implant overdentures. Like our previous webinars with ITX Pros, this is going to be an interactive webinar, meaning that throughout the presentation tonight, we will have about 5 or 6 questions where a poll will come up when the question is asked, and you can select an answer for it there. We will then get the data from the poll, and we'll go and kind of go through the question there. Again, there will be about 5 or 6 of them throughout the webinar this evening. Throughout, there's a Q&A button on the Zoom meeting here. So if you have any questions in regards to anything that we're talking about, or anything about the Mish Resnik Implant Institute or ITX Pros, you can ask it in the Q&A section, and one of the panelists here will be answering it throughout. Additionally, at the end, AK and myself will be answering questions that were also done throughout. And then after this webinar, you will be receiving a CE credit via email sent out by ITX Pros. So with that being said, we have a lot to cover this evening, so we'll dive right into it. But this evening, we're going to be talking about mastering full arch implant restoration, specifically removable overdentures. So we're going to start this webinar off this evening with a question. And first question of the night is, which full arch prosthesis has the greatest failure rate? We have A, the maxillary overdenture, B, a maxillary fixed prosthesis, C, a mandibular overdenture, or D, a mandibular fixed prosthesis. Do you have the poll up, Robert? Ah, there it is. Great. So over half of us got that there. Maxillary overdenture being the one with the greatest failure rate. So let's dive into that here. So again, greatest failure rate, the maxillary overdenture. So if we look at the literature and the studies here, this is a great systematic review that looked at all full arch prosthetic complications. And when dealing with removable overdentures, the complication rate was 5 to 10 times higher than a fixed prosthesis. The number of complications was over 1.5 times in that 5-year mark. And with implant loss at 5 years, it was 4 times greater with overdentures. If we look at just looking at overdentures at the maxilla and mandible, this is a great study by Goodacre that found that 19% of implants failed on a maxillary overdenture, where only 4% failed with a mandibular overdenture. So that's 5 times greater failure rate in the maxilla in regards to overdenture, which is rather alarming there. If we look at other systematic reviews, this one looked at 46 studies with a mean time followed at 5 years. Overdenture success on the maxilla was, almost under 80%, where on the mandible it was 100%. So that's, rather alarming that overdentures on the top are, have that much morbidity or failure. If we look at what these implant complications are or can happen, retention loss is going to be our most common one. That 1/3 of overdentures patients are going to come back with lack of retention or inadequate retention. Implant loss, 20% in the maxilla. So again, a lot of implant failures in regards to maxillary overdentures. Relining, clip attachment are other common complications that we'll dive into throughout this evening. So with that, how can we increase the success rate of implant overdentures? Because we don't want to be doing something in our practice where every couple years, 1 of every 5 patients is coming back and you're having to redo the prosthesis or go into more surgery for them. We want to do something where we do it once and, hopefully never really see the patient again or have to deal with it. So we want to do it the right way. So what we'll do is we're going to be going over and understanding the different types of overdentures, how we can prevent these complications and increase the success of a removable prosthesis. We'll also go over the biomechanics to understand why we have different types of overdentures for different types of scenarios and understand how each denture is going to be functioning. We'll talk about splinting or not splinting. What are the benefits of splinting for removable overdentures, and when do we not splint? And then we'll also understand the attachment principles. So each attachment is built differently to handle the parafunction and force of the opposing arch there. So we want to be selecting the correct attachment as well as utilizing it in the correct manner. So first, if we look at our edentulous arch, we have different prosthesis types. So it was developed by Mish in the 80s, and this is probably one of his most taught about classifications here. We have 3 of the fixed classifications. That's an FP1, FP2, FP3. We're going to dive into that at the next webinar in January. But we do have 2 removable classifications. We have an RP4 and an RP5. Both are implant overdentures, meaning it's a denture that has implants in it. However, both vary greatly here. So we first need to understand that there's 2 types of overdentures when we're making dentures for patients here, and classifying them the proper way will allow us to have great success with them. So again, this was developed by Carl Mish back in the 80s here. We have an RP4 and an RP5. An RP4 is going to be an overdenture that is completely implant supported. So we're not relying on the soft tissue at all to maintain that prosthesis. The implants are helping keep that prosthesis in place as well as during function, and we're not relying on the soft tissue. We then have an RP5, which is an overdenture that is soft tissue supported with secondary implant support, meaning that during the forces and during function, we're relying on the soft tissue as well as the implant. So two completely different prostheses here. And we do have RP4 and RP5 on the maxilla and mandible. So again, an RP4 being a completely implant supported prosthesis, whereas an RP5 is an implant retained. However, it's not supported by the implants. So where did Carl come up with this back in the 80s? And that was based on the prosthodontic literature. So if we look at some of the basic prosthodontic principles, we have what's called the stress-bearing areas of an edentulous arch. And if we look into what a stress-bearing area is, it is going to be the anatomic area that provides the denture support under masticatory loads. So this is going to be the part of the anatomy on the maxilla and mandible that is able to withstand the forces of function every day, parafunction, and all that. So generally, it's going to be fibrous connective tissue with nice keratinized mucosa, cortical bone underneath, and it's going to be positioned at an angle to have a favorable response against those vertical occlusal forces. So if we look at the maxilla, we have our primary and our secondary stress-bearing areas. Our primary stress-bearing areas are going to be the hard palate there. Secondary are going to be the residual ridge. So that means that, with an RP5 prosthesis, we want the forces to be accepted by the roof of the mouth there. So this is going to be an overdenture where we're going to, need to maintain the palate with secondary support from the residual ridge here. So again, transferring this over into an overdenture here, that's going to mean that we're going to have the palate on that overdenture to help accept those masticatory forces. The problem being, a lot of people, they come in and they think that they're going to get an implant denture and just cut the roof of the mouth out. The problem with doing that is now you're losing the primary stress-bearing areas. So the roof of the mouth is meant to take those forces. Now we're transferring all the forces onto those implants. And again, removal of that. And that's where we get into the issue with these high failure rates or low implant survival rates. So again, maxillary overdenture, 71% implant survival at 5 years. So that's not good. And we can be better than that. So why does the maxillary overdenture have the highest complication and failure rate? It comes back again to having no palatal coverage. So whenever we remove the palate on a maxillary overdenture, that's leading to higher complications. There's certain situations that we'll talk about where it's indicated, but just because somebody has implants in the maxilla doesn't mean that we need to take the palate out of it. So when we do remove the palatal support of an implant overdenture, it does result in greater load and increased stress at the implant surfaces. Thus, this study actually found that the palate was more important than the attachment system being used. So, it would even help with the retention of the prosthesis. So just as a kind of quick summary for a maxillary overdenture, we have two different types. We have an RP4. This is going to be where there's no palate involved. And we're going to actually treat this kind of like a fixed prosthesis. It's going to be a fixed prosthesis that the patient's able to remove every night and clean, the attachments. Then we have an RP5, which is pretty much a denture that has secondary support coming from the implant. So just like a complete denture, if you cut out the roof of the mouth, it's just going to fall down. So we need the roof of the mouth here to help with the retention as well as accept those masticatory forces. Like I said, we do have a stress-bearing area on the mandible as well to decipher between an RP4 and 5. So that brings us into our second question here. Which anatomical area is the primary stress-bearing area of the mandible? We have A, the residual ridge. We have B, the buccal shelf. We have C, the retromolar pad. And we have D, the hamular notch. Okay, good. The majority of us got that with the buccal shelf there. So the buccal shelf is the correct answer here. So on the mandible, the primary stress-bearing area is going to be the buccal shelf. And if we dive into the buccal shelf here, if you remember back in dental school, border molding for complete dentures with the green stick compound, the buccal shelf is a flat area back bounded by the crest of the ridge and the external oblique line. This is going to be nice cortical bone that is not going to resorb. So over time, we're going to maintain the bone in that area. Thus, that would be the best part of the mandible to be kind of withstanding the masticatory forces. So from the diagram there on the bottom left there, up around there, just showing the extensions here for the adequate buccal shelf there. And they're showing the difference on the top there. So on the top right, we have, good buccal shelf support, where the top left, that's going to be an RP4 prosthesis where we have no soft tissue support in the posterior there. So With a mandibular overdenture, RP4, we're relying completely on the implants to support the prosthesis as well as take the load of function. So you really have minimal extensions onto the soft tissue or vestibule. In an RP5, it's pretty much a border molded denture with secondary implant support there. So we're relying on all that good soft tissue and bone in the posterior there to help maintain the prosthesis. Consequences of fabricating an RP5 instead of an RP4 instead of an RP5. So, problem with just taking the palate out on every single implant denture on the maxilla, you're going to have greater attachment wear and maintenance. You're going to have those implants withstanding the forces when in all situations they may not be adequately engineered to. We're also going to have increased stress at the implants there, leading to increased failure that we see throughout the literature. And then we're also going to have a more frequent need for reline there. Since the implants are taking all the force there, the soft tissue is going to continue to resorb, and we're going to need more adequate relines in the future there. So now we'll dive into overdenture biomechanics, and we'll talk about two different categories of this: A, the number of implants, and B, the positioning of these implants for overdenture success. So if we start and talk about the number of implants necessary for an implant overdenture, you're going to find some dentists down the street that like one implant overdenture, the cyclone, where you just put one right in the midline, and that's what all their patients do. Then you have others that think 2 implants is great. That's all the patients need are 2 implants. You have the 3 implant guy down the street, 4 implant, 5 implant, and then you have the guy that's been married a couple times and he puts as many implants in as he can there. So we want to have a kind of a criteria for this. We shouldn't be treating each patient the same. There's certain situations where 2 implants are indicated, but there's other situations where maybe 5 or 6 implants are indicated. So we'll first kind of talk about the maxilla. And if we look at the literature with how many implants are needed to support an overdenture, there's some studies out there that say 2 implants have great success. Others show 4 implants are needed for an implant overdenture. Others are greater than 4 implants. Some say 6 implants. Some say 7 implants. With that, the literature is all over the place. There's no consensus on the implant number, the positioning, and in all of these articles, none of them decipher between the 2 types of overdentures that we talked about. They just generalize it as overdentures. But from earlier, we talked about the RP4 and RP5. Both are overdentures, but they're both made completely different there. So there's a certain number requirement that we look for in an RP4, and there's certain numbers that we look for in an RP5. So if we go into that, when we're picking the number of implants on the maxilla, we're looking at 2 things, 2 main things, one being the force factors and 2 being the arch position with it. So, and from that, we'll plan with how many implants and the spots of these implants here. So if we look at somebody, or like we said earlier, the maxillary RP4 is going to be treated as a fixed prosthesis. So this is going to be primarily supported by implants. We're not relying on soft tissue support. So for an RP4 overdenture, we're going to look for more implants because we don't want to overload the implant. So if we look at the arch form of an RP4 or of an edentulous maxilla, we have 3 different arch forms that you will see in patients, one being a square arch form, the other being an ovoid arch form, or the latter being a tapered arch form. And these arch forms will dictate where we need those implants to limit the cantilever and improve the biomechanics of the overdenture. So if we look at placing 6 implants, this is going to be somebody with a square arch form, minimal occlusal forces. So square arch form, you can see the 2 implants in the canine. We really don't have anterior a cantilever here. So we'll get some implants at the cuspid and molars. Those are going to be our top 2 sites. And then you'll get some in the bicuspid position to make 6 implants there. 7 implants, this is going to be somebody with an ovoid arch form. So in the bottom right there, you see on how there's a little more cantilever off the anterior there. So by putting an implant in the anterior maxilla there, that's going to limit the anterior cantilever there to improve the biomechanics and acceptance of those occlusal forces. In 8 implants, this is going to be somebody with a tapered arch form. So you can see on how from those canines forward, how far of a cantilever you have from the teeth there. So from this, we're going to look into putting 2 implants in the anterior maxilla to help limit that cantilever and accept those anterior forces there. So these are all considerations that we're taking into when planning out the implant sites, as well as the implant numbers for our maxillary RP4 overdenture. When we're dealing with an RP5, again, primary stress bearing area is going to be the palate there. So that's, we need that. And then secondary is going to be the implants. If we look at how many implants do we need for somebody that is going to be receiving an RP5, generally anywhere from 4 to 6. And that's going to be dependent, again, on the force factors here. So since we have the palate that's going to be accepting the majority of the forces there, we don't need the implants as far posterior, because that palate's not going to change. That's going to be dense cortical bone, thick keratinized tissue there. That's going to be accepting those, forces there. The implants are just going to help kind of support it in the anterior there. So 4 implants is going to be somebody with, not as much force there. We may look into 5 implants with somebody with a little more force, and then 6 implants with somebody that has a lot of force there. So, all things that we're going to take into consideration when planning the number of implants for an RP5 prosthesis. So quick conclusion on how many implants. Generally for an RP4, looking anywhere from 6 to 8 implants, depending on the arch form as well as the force factors. RP5, generally anywhere from 4 to 6 implants, again, depending on the force factors for that. And by following these kind of just basic principles and not treating every maxillary overdenture the same, we're going to decrease the implant failure rate seen with the maxillary overdenture. Going into mandibular implant positioning, another one of Mish's classifications here is in the anterior, separating 5 different sites interforaminally there. So A through E. Generally, the majority of the population will have adequate bone in the anterior maxilla to get implants to help support a lower overdenture there. So like the maxillary implant overdenture, you have doctors down the street that like 1 implant, 2 implant, 3, 4, and several implants there. So kind of a basic way to classify it here. This again, just showing the A through E positions here, but like the maxilla, we do have the RP4 and the RP5 prosthesis. And this is where patient education really comes into play here. It's better to get out ahead of making an RP4 and an RP5 prosthesis similar to the maxilla. You don't want to put 4 implants in and then go to make the prosthesis, then let Mrs. Smith know that she's going to have the roof of the mouth covered with the implant overdenture. That should be done prior to any surgery going into it. And like here on the mandible here. So if you're going to be putting 2 implants in on a patient, they need to understand there's still going to be movement of that prosthesis. Whereas if they were going to be getting 4 or 5 implants, there's going to be a little less movement of the prosthesis there. So that's where grabbing the chair in the room and showing Mrs. Smith, if we do 2 implants, it's still going to rock back and forth, kind of like a seesaw there. But if we go 3, 4, or 5, we have a more stable chair there that's going to be withstanding the forces, as well as increasing the amount of retention and support there. So patient education is really key when it comes down to overdentures on both the maxilla and mandible. With mandibular overdentures, ways to increase the success. These are kind of the 2 big things that I look for. One is minimizing the cantilever, and 2 is maximizing the AP spread. So showing the top 2 images there, talking about the cantilever, you can see these are both 2 implants that were placed. And just from that location, you can see not only the posterior cantilever, but we also have an anterior cantilever there. So those 2 implants are acting kind of like the fulcrum in a seesaw there. So, over time, you're going to be seeing that patient every 3-6 months and realigning the anterior and the posterior, just because they're going to be rocking it back and forth. Where if those implants are placed a little more anterior, where it shows on the right there, you're really not going to have that anterior cantilever. You're just going to have that posterior cantilever, but you're going to maintain the buccal shelf in that overdenture. So that buccal shelf is going to help resist the forces in the posterior and also accept the occlusal forces. So really the maintenance on that is going to be minimal compared to where those implants are. We're also going to look to maximize the AP spread. So if we're able to get more than 2 implants in, we have what's called the AP spread. So if the one on the bottom left there, really those implants are in a straight line. So they would have been just as good with just 2 implants. That third implant, just is more money in the doctor's pocket, but it's really not going to help that patient out. Where that overdenture on the lower right there, you have 4 well-positioned implants, similar to kind of the 4 legs on a chair. So that's going to be a very stable denture and will most likely be an RP4 prosthesis. So looking at the RP4, generally looking anywhere from 4 to 5 implants here. Like I said, the majority of the patients, we just place them interforaminally there. So in between the 2 foramen, generally you're able to get 4 to 5 implants on the majority of the patients there. And that would give them adequate support where you really wouldn't need those soft tissue extensions in the posterior. So really just the implants in the anterior are enough to help keep that overdenture in place. The RP5, this is generally when we're dealing with 2 to 3, and in some cases 4 implants, where we do want to keep that buccal shelf in the posterior, and that's going to resist the resorption in the posterior mandible there and limit the amount of need for a reline. So that buccal shelf support in the posterior is going to help resist the occlusive forces and help keep that a stable prosthesis. With that being said, we'll now go into some of the attachments. So when dealing with overdenture attachments, one of the decisions we have to make as the restoring doctors, whether we're going to do them independently or splinted. Independently, meaning that each implant has its own attachment. Splinting, meaning where all the attachment or all the implants are connected together and the prosthesis snaps into or is retained by that supporting bar here. So we'll now go into 2 questions here. The first one being, in the maxilla, does splinting or independent overdenture attachments have a higher success rate? A, splinting, B, independent, or C, splinting is equal to independent, being that they're both equally as successful. Great. The majority of us got that there, where splinting does have a higher success rate. So on the maxilla, splinting does have a higher success rate than independent attachments. We'll now go on to the second part of the question and change this over to the mandible. So in the mandible, does splinting or independent overdenture attachments have a higher success rate? A, splinting, B, independent, or C, splinting is equal to independent. Okay, good. So splinting was just there. So on the mandible, actually, it's a little different, where splinting is going to be just as good as independent. Throughout the literature, both of them are pretty much neck and neck. And if we look at a really good systematic review, this one looked at splinting versus not splinting. On the maxilla, 4 implants with a bar overdenture at a 97% implant survival rate or success rate. However, when we went 4 implants and they were independent, that dropped down into the about 89%. If we looked at the mandible, the bar and individual had pretty much a 97, 98% survival rate. And that's validated by several studies in the literature, again, this being a systematic review there. So on the maxilla, generally splinting them will lead to greater success, and on the mandible, generally a bar and individual are going to be the same. And really one of the big things or the 2 reasons that is validated is on the maxilla, generally in the pre-maxilla, everything's going to be flared outward. So it's very difficult to get those implants parallel, especially going backwards from like the canine to the molar, where on the mandible, generally they're all very easily paralleled. Second being the bone density. On the maxilla, we're generally dealing with D3, D4 bone. On the mandible, we're dealing with D1, D2 bone. So a lot tougher bone there. So both of those reasons are probably the top 2 reasons why the mandible generally is a little more successful with individual, or individual and bar are going to be the same success. For the maxilla, a bar supported overdenture is going to be far superior than independent. So what are the advantages of splinting, and why would we splint? Like I said, one is it's going to parallel the implant. So more of a case on the maxilla, we're dealing with the pre-maxilla. They're always going to be usually flared outwards. Whereas on the mandible, they're generally always going to be parallel. But by doing a bar and splinting them together, we're able to kind of parallel all of them. So all the attachments in the bar are going to be 100% parallel. They're done by either now they're all milled. So all those attachments are going in at the same angle there. Better stress distribution. A lot of finite element analysis studies out there showing the forces that these are taking. And by connecting everything together, when you bite in one area, all those implants are kind of helping support it there. Where if you have an independent attachment, if you bite in the very back right, the implant closest to the back right is going to be the one that's primarily taking that. So a bar kind of connects them all together, and similar to the reason that the all-on-4 concept works by all implants kind of carrying it together. That's kind of the way the bar overdenture is going to work there. So again, splinting it, you have less stress on the implants, abutments, and the bone. We're going to have cross arch stabilization. So as I just said, if you're biting on the right, that left side is also helping you. Whereas independent, if you bite on the right, generally that right implant is taking the majority of the forces. So you're going to get, even then less attachment wear, just because all of them are helping it stabilize there. Avoid overloading single implant. Again, splitting attachments reduce the forces to the implants, the bone, as well as the attachments. We have less maintenance. So studies show that with a bar, you're going to have less maintenance adjustments, less of a need for a soft tissue reline. Just with the bar, you're getting more support there. Everything's parallel. Greater retention. Studies show that splinted bars, again, you're paralleling all the attachments there. They're going to be much more retentive than individual attachments, which are never going to be 100% parallel. Greater success in the maxilla, as we said there. So what are some of the advantages, or why would we be doing independent attachments? Probably the biggest one is going to be cost. These are prices from Glidewell's website, the biggest lab in the country. A locator supported overdenture is under $700, and I believe that's up to 4 implants, where they'll send you the locator attachments as well as the denture. Whereas if we look for a locator CAD/CAM milled bar, we're at almost $3,200, where you look at their fixed prosthesis and it's $3,400. So you look at what you're getting for the cost. Generally, you put a fixed prosthesis in, and after maybe 1 or 2 bite adjustments, you really don't see that patient back. Whereas with overdentures, you're seeing these patients back, sometimes a little too much there. So, the cost is, 6-fold there of what a locator overdenture does compared to a locator CAD/CAM milled. And the majority of the dentures now, or bars, are now milled there. So out of milled titanium. Second is going to be the interocclusal space. So we have interocclusal space requirements for individual attachments as well as bar overdenture attachments. Third being the hygiene. So even though the patient has a removable prosthesis and they just take it out and put it in a glass of water at night, they still have to clean these implant attachments. And it's very difficult even for the dentist to get underneath those bars, especially relaying to the lab that you need adequate space. Generally, you need 1 to 2 millimeters underneath that bar to be able to clean adequately. And that doesn't happen too often, where a lab is going to understand that or deliver that. Generally, these are going to be hugging the tissue, and it's near impossible for the patient to get under there. So whereas with individual attachments, they just brush them like they're brushing their teeth, and that helps keep them clean there. So individual attachments being a lot more cleansable there. So if we go into the attachment principles, we have space requirements, we have the movement of these attachments, and then we have the troubleshooting of these attachments here. So if we first go into the space requirements and ask how much space is needed for an overdenture, how much is needed for an RP4 bar supported or how much is needed for a RP5 individual attachment. If we look at the literature, like the literature on the majority of things in dentistry, it's all over the place, ranging anywhere from 7 millimeters to 14 millimeters. Unfortunately, there's really no standard classification on how much space is needed for these attachments. There's really no consensus out there. If you look at what Zest says, Zest is the company that makes the locator. They say you can get away with, about 8 millimeters for a locator attachment. I think that's a little on the low end. With that, you need space for the locator abutment. You need space for the male and the female attachment. You need space for acrylic. You need space for the denture tooth. And you need space for a reinforcement if you're going to reinforce with metal or fiber mesh. So adding all those up to it, I think 8 is being a little lenient. Generally, I'm looking for usually around 10. And the problem is if you put that implant in on the basis that you're going to have 8 millimeters of space and that patient breaks the prosthesis, then what do? It's always better to have a little more space when dealing with removable prosthetics than to, cut the denture teeth down and that denture base is as minimal as possible. And then you're dealing with, a high incidence of fracture there. Similar to the individual attachments, if we look at the literature regarding the overdenture with a bar, it ranges all over the place, anywhere from down to 11 millimeters up to 17, 18 millimeters. So again, there's no consensus with an overdenture with a bar. And unfortunately, what's difficult with bars is each lab that you use or each company that you use to manufacture these is making their bar somewhat different. The bar has a lot more versatile attachments than the individual implant. So with it, it's very difficult to kind of classify a set space requirement with a bar, implant, overdenture, especially with as things progress, the bar attachments are generally getting they're changing them up a lot. So if we kind of do just quick little math here on how much is needed for a bar, these are numbers that we've at the Institute kind of broken down. And generally we're looking for over 15 or above millimeters of space for an implant overdenture. That's going to give us, generally you're going to have about 3 millimeters of soft tissue from the bone. And then in between the soft tissue and bar, remember, we need space to clean. So we're looking from 1 to 2 millimeters. And then by the time you fabricate the bar and put on the attachment, you're anywhere from 3 to 6 millimeters. And then you need adequate space for acrylic and denture teeth, so 6 to 8. So at minimum, when doing a bar overdenture, you want about 15 millimeters of space. If we go into attachment movement, there's several different principles that you need to kind of understand when figuring out what type of attachment to use and understanding how this overdenture is going to function. We've already talked about the RP4 and RP5. By doing an RP5, we're relying on the soft tissue to help support the denture. So, using those, there's many different types of independent attachments out there. If you've never heard of Preet, they're a great resource. You go to preet.com and you can actually get this restorative prosthetic book emailed to you for free. They will have every restorative component in implant dentistry. They have an impression coping for any implant out there. Every attachment, you'll be able to get parts for it, as well as with their website. If you're trying to identify an implant that comes in your practice, if you send them the PA, they will not only send you the implant specifications, but they will also send you the necessary parts that you would need to restore it. And I used them this week, and they got back to me within 15 minutes of what implant it was and the necessary impression copings I needed for it there. So if you've never heard of it, preet.com, especially if you're restoring dental implants. So we need to understand the attachment biomechanics, and we have two main definitions when talking about the biomechanics of attachments. We have resiliency and non-resiliency. So what resiliency means is this is slight movement of the denture onto the soft tissues. So when you have a resilient attachment, you're minimizing the forces to the implant because you're relaying some of those forces onto the soft tissues of the either maxilla or mandible. When we're dealing with resilient attachments, we're going to have attachments that permit vertical movement. We're going to have some hinge movement, so kind of like a seesaw. We're going to have some that have rotation movement, and then we have others that have translation and spinning. We then have other attachments that are classified as non-resilient. So these are going to be where there's no movement between the abutment and the implant, where pretty much that implant abutment and that attachment are taking 100% of the forces there. So we're not relying anywhere on the soft tissue there. So those are two of the big categories when deciphering between implant attachments. And we're just going to talk about a couple here this evening. We're going to talk about the locator, which is probably the most common attachment out there. That's going to be one of our resilient attachments. And then two that I've used rather recently in my practice, non-resilient attachments, which is going to be the conus and the bredent. So we first need to understand that attachment movement does not equal prosthesis movement. Attachments are made to move. Prosthetics generally are not made to move unless they're, that's how we designed it there. But there's two different types of movement when describing it there. So again, we have the attachment, which is made to move, and then we have the prosthesis, which is ideally not made to move there. So looking at a locator, which again, this is going to be our most common attachment in implant dentistry right now. These are made with 6 ranges of movement. So that attachment, when it's engaged into the implant abutment, is going to move mesiodistal, buccolingual, occlusal, and apically. That's the way they're designed. So they have 6 ranges of movement built into it. And the way this works is there's on the engaging ones, we have dual retention there. So we have a button that goes on the inside. And the way that this is a resilient attachment is the male remains in static contact with the attachment, while that denture cap inside the denture has a full range of movement. So as that patient's going through their excursive movements there, the denture cap is moving, whereas the male remains in static contact there. So this is what we mean by attachment movement rather than prosthetic movement there. This is another example here. So as that patient's moving into their excursions or eating their food bolus, the denture cap here is moving around, whereas that male attachment is remained in static contact with that locator abutment. Locators, they say that you can get 20 to 40 degrees. I think that's pushing the limits there. If you're trying to get something to engage 2 locators at 40 degrees, I think you're going to be there for a long day, or see that patient back rather frequently. I think they exaggerate those numbers. One thing that I have done when dealing with excessive divergent is going to a multi-unit with the locator abutment on, and this has worked pretty well for me when you have the necessary restorative space. But pretty much to combat the divergence of these implants, you put on a multi-unit, so that's going to redirect where the prosthetic engages on. So you're going to have 2 different abutments. You're going to have a multi-unit down here at the bottom, and then you're going to have this, which is going to get screwed onto the multi-unit. So they come with a little cap here, as well as the locator attachment. Again, this is going to increase the amount of interocclusal space we need. However, it's going to allow for a much better passive fit of the prosthesis. And like I said, I think 40 degrees is fake news, we'll call it. But this is one of my cases here where the patient had 6 implants up here. So and he actually had a failing implant hybrid, and he wanted something removable, so it was easily cleansable. So I put 6 multi-units on there. Here's the cap, and here's the little sleeve. And this is just me up here showing the interocclusal space needed with it. You put out the similar blockouts, and then you pick it up here. So for this, we ended up picking up the other 2 there to make it 6 implants. But if I was going to make 6 implant overdenture with then that divergent, I would never get the passive fit that you would with the multi-units. So that's a good tool to have. Another attachment that I've used in my practice is a non-resilient one. This is going to be the Atlantis conus attachment made by Dentsupply. And what this is again, this is a non-resilient attachment. So the implants are taking 100% of the forces. You're not relying on the soft tissue at all to hold it in. But there's 2 components to it, where you have the Atlantis conus abutment, and then you have the Syncon cap. The Syncon cap is going to be what's going to be in the denture. The Atlantis conus abutment is going to be screwed into the implant. And the way this system works is these conus abutments are custom milled based on each case. So you take an implant level impression, you send it to the lab, and they mill you these the conus abutments. So depending on how many implants you have, they mill you a specific abutment for that implant for that patient. And these abutments are made similar to when you're surveying a RPD. They're made where they're 100% parallel. So, it's pretty much going to function like a bar overdenture, but you have the advantages of it being a individual attachment here. So this is one of my cases where we had 6 implants on the bottom here. So these are the conus attachments here. So you can see the parallelism with it. They'll actually send you a seating jig. So on the right side there, that's a seating jig because these are going into implants and they can go in one of 6 different ways there. So we need to make sure that all these implants are as parallel as possible. So they send you a seating jig to make sure those implants are at the correct location as well as the correct timing. And then these are the syncope caps that I was going to be picking up intraorally. This showing the seating jig here. For this case, I used rubber dam to block out underneath to prevent any excess. And then this is just some PIP paste showing that we have no markings anywhere in between these syncope caps. So being that this is going to be a RP4, a completely implant supported prosthesis, we don't need any soft tissue support. So these implants are taking on all of the forces. And one thing that I, come to find from these is they fit very well, if not too well. For this case, I had to put little divots in the front here, and we actually had to give the patient a tool to get out. Because once this is in, it's in there pretty good. So it is pretty much a fixed prosthesis. But for somebody with any dexterity issues, it's rather difficult to get out there. But that does work well. And the lab cost of this is actually a little cheaper than even a bar overdenture. So that's another cool attachment that I've used. This is our favorite attachment for dealing with bars. It's called a Bredent attachment. And what this is it's pretty much an offset ball attachment. So rather than the attachment being on top of the bar, invading the interocclusal space, our attachment here is going to be on the buccal or the lingual. So we need necessary height for the material of the bar. Generally, you need 3 to 6 millimeters for a titanium milled bar. Generally, you put an attachment on top of it, that's another 3 to 4 millimeters here. By putting the attachment on the buccal or lingual, we don't need any more space interocclusally because that's coming on the buccal lingual there. So, and that's what this Bredent attachment is. So pretty much it's a little ball insert that goes on the buccal or lingual there, meaning that you don't really need any more interocclusal space for it. So it's a really good attachment. Again, ideal for compromised vertical. You have great retention of it, and similar to a locator, they have it where you have different levels of retention. So if you do bar implant overdentures and where you're worried about interocclusal space, the Bredent is a great attachment for it. And it's very mainstream, so any lab can do it there. We're going to finish this evening with just some attachment troubleshooting. So just going through some of the complications, some of the more common complications and how we go about treating them. Again, if we look at one of Goodacre studies here, looking at implant overdenture, retention loss is going to be the far most superior complication that we're going to see in practice with it. This is a study that looks specifically at locator complications, and they found that the most common one is the need for repositioning of the denture cap. So due to either poor lab processing or intraoral processing, that patient comes back the next day and, hey, the denture isn't going in anymore. So denture cap maintenance, highest in the first year. Generally with all these implant overdentures, you'll see that patient a couple too many times over the first couple months, and then they'll kind of disappear because they get used to it. But and a lot of that goes back to the patient education, where they think, oh, I just need 2 implants and I can eat steak. Yeah, you're not going to be eating steak with 2 implants. And that's where patient education comes into play. And the locator wear being the highest on the maxilla, again, due to the divergence of the ridge and the off-axial forces there. So one of our complications with the locator is patient will come in and they'll say there's no retention, or you pick it up and then you got to put it back in and it's just not engaging. one of the issues is going to be tissue impingement. So we need the abutment placed at minimum 1.5 millimeters above the tissue. So it goes to selecting the correct size. One of the tests of doing this is you grab one of the locator impression copings and you push it on there. And if there's tissue blanching, that means that you need a higher size locator, or there's going to be an improper fit there. So we shouldn't have any blanching of the tissue when the locator is going in there. When measuring these locator attachments, the tissue measurement should be the deepest tissue height. So that being, if on the palate, the tissue is a little thicker, you need to measure to the tissue on the palate. You don't just go to the shortest tissue, because circumferentially you need adequate space for that locator abutment. When measuring it, the locator abutments have a built-in 1.5 millimeter. So when you stick the probe down and you hit the implant there, whatever that's at, that would be the size of the locator abutment you would be ordering there. So if the pocket's 3 millimeters, you get a 3 millimeter locator attachment that will bring you 1.5 millimeters above the tissue. A second being no retention causes a worn out abutment. These locator abutments are gold coated, and over time they're made to, when they're wear, you see silver. So if you see somebody that, they're at the highest strength locator abutment and, it's not engaging, take a look at the locator attachment. If you see a lot of silver around it, it's worn there. Generally, the way I treat these cases is when you see somebody back for maintenance or in hygiene and they have any silver on their locator abutment, mention it to the patient that in the future they may need a replacement of the locator attachment. You don't want to defer that until it's too late and then tell the patient they need to spend $1,000 for a new locator, because then they're not going to be happy that you never mentioned it in the past. Another being food impaction. So patients still do need to brush these independent attachments. The locator at the very top there has a little triangle where it notoriously catches food. And when you're using one of the normal range locators, that button is made to go into the aspect of that locator. So if there's food in there, the locator is not going to snap in there. So it's very difficult for patients to clean it, but again, explain to them when you're making them the overdenture that they need to clean it, water pick it, and then when you see them back, generally you grab a little explorer tip and you can remove it. Another common complication is the retentive inserts falling out, and this is most likely attributed to the locators being too divergent. If this is the case, you want to change to the extended range males. These are not going to have that internal abutment or internal button. So without this internal button, you have greater divergence. Again, Zest says up to 40 degrees. I think that's a little false, but you do have a little more extended range. So this is just showing the ones on the right there, the extended range. Another common complication is having too much retention. So you don't want to start the patient out at the most retention. You want to kind of ease them into it. Problem with starting them out the most retention is they're never going to take it out. Or, if they start the most retentive, then what do you do when those get loose? So with that, we'll do our final question in the evening here. According to Zest, what is the ideal initial retention for an overdenture case? A, to start with 6 pounds of retention. B, start with all clear attachments. C, leave black males in for 1 week. Or D, start with all extended red males. Okay. Start with 6, leave black males in. Okay. So according to Zest, what they recommend is 6 pounds of retention. They find that to be most adequate in the majority of patients there. So being that back, if we look down here, these are the pounds of retention we have in it. The black males they're made a little differently than these other males down here, the colored. The black males transfer more forces down to the soft tissue. So generally, we pick them up with the black males and then we change them to the adequate level of retention there. But according to Zest, they like 6 pounds there. So another complication here is the prosthesis does not seat directly at the pickup. Most likely the cause is those pickups are not passive, meaning that they're too divergent. One way to prevent this is pick up the attachments one at a time. Probably the biggest tip here is when you're picking up the attachments, you don't have the patient bite down with force. You just have them bite down softly. So lightly occlude. You don't want them to bite down and their masseters are popping. With that, if they're biting down that hard, they're compressing all those tissues. And that's going to lead to when they go in and put it in, it's not going to go in passively. So always have them bite down gently when you're picking up these locator attachments. Again, we have the black processing male or the yellow. Yellow is generally used for a bar because it's going to make it closer down into the bar, where the black is going to have a little more space where it's transferring some of that pressure to the soft tissue. This is probably one of the more frustrating ones when you pick up an attachment and then the prosthesis is rocking. And, one of the causes is inaccurate direct pickup where you're overloading the tissue. Another thing that I found is this is when usually it's time for a reline there. So, a patient comes in for their 6-month maintenance and you replace the attachments and it's still rocking there. So one of the ways that is cheap and quick to fix this is I'll grab some green stick compound. So for this middle case, this was a 2-implant RP5 design where I changed the attachments and they were still rocking. So what I did was I put a little green stick back here in the posterior, similar to a metal tissue stopper, like an RPD design or RPD framework. That green stick back there is going to pretty much serve as just a reline back in that buccal shelf there. And I'll do that. I'll put it back in. Now the rocking went away. Okay, Mrs. Smith, we need a reline here. And I'll keep that green stick in there during my reline because that's going to mean that I'm going to keep that same vertical there. So it's going to act as a tissue stop similar to what the tissue stop is on an RPD design. So, that's a really, really good trick when dealing with these. Great reline materials, Mucopren from Kettenbach. It's a, long-lasting kind of permanent reline that works very well there. Denture tooth debonding. Again, this is when we're going to be invading that interocclusal space around denture teeth. We need at least 2 millimeters of acrylic and doing it, verify the occlusion. Overdenture fractures. All my partials, I reinforce them, or all my overdentures, I reinforce them with either metal or mesh. Even if I have the full palette in there, I'll put it with metal or put mesh in there just because these attachments take up a lot of space and you need adequate material around it, bulk of acrylic to prevent breaking there. So when we make these overdentures, the patient's force factors are going to, almost double there. So, we need to structure them in a way that they're able to withstand those forces. Difficulty picking up. So I don't understand why they send you locators that are, very shiny with no retention. I don't know how you're supposed to get acrylic. One of the ways I do it is I sandblast it. So, and you can see on the bottom right there, a sandblasted one versus one that's not sandblasted. I don't know why they don't just send them sandblasted. There's no need for them to be that shiny. And this is going to be your worst complication. Locking the denture under the bar or attachments. Never do this. And hopefully if you do it once, you never do it again. Because it turns a 30-minute appointment into a 2-hour appointment, and then you have to start from scratch. Always block out these attachments. Specifically when dealing with a bar, it doesn't take much acrylic. It just takes, a little drop of acrylic underneath this bar for you not to get that denture up. So, several different products on the market, Oraseal. This is a really good material, universal denture material, where it's like a blue gel. So this is one of my cases that I picked up here, where it's like a blue, similar to like flowable composite there, and you cure it, and then you're just able to flick it out with an Explorer after. That works really well. Permablock. Another thing is using blue rope wax. It's not going to move as much as red rope wax, but you always want to block these out. I've used rubber dams, in the past as well there. So with that, to kind of conclude the webinar this evening, overdentures are very successful when done correctly. Not all overdentures are the same. We must understand that there's a difference between the RP4 and RP5 prosthesis. Educate the patient, do it before the implants go in. Again, don't tell Mrs. Smith that after she went, 6 months healing, that she's still going to have the palate on her denture. Understand that splinting is beneficial in some cases, and then understand the basic attachment principles built in within each attachment that we're utilizing. We do have 2 more parts of this restorative kind of cookbook here. The next part will be on full arch implant restorations, covering fixed restorations, and that'll be in January. And then in February, we'll have our final one talking about all on X and immediately loading techniques. The previous tonight's and the one last month can be found on the ITX Pros YouTube channel. We also have our Miss Resnik implant curriculum that's underway here in Orlando. We'll be here for the next through the summer here, and then we'll be going back in Dallas. You can find more information on it at the website there. And then we also have our 3-day Prosto Bootcamp, which is 3 long, grueling days here in February, where we go into everything in depth from single restorations, removable, and fixed restorations. It is very lab heavy. So with the locator attachment, you'll be picking them up, taking impressions, and we'll be doing all that in February. Thank ITX. They do all my surgical guides. They help us out at the Institute. They've really streamlined the surgical guide workflow. This is their new kit down here on the bottom right, keyless. That works great. And thank you again, guys, for having me on tonight. Does AK want to take over?
Thank you so much, Chris. I mean, again, as usual, another amazing presentation, another amazing lecture. I started to have this feeling that we're going through like a mini residency for implant pros. This is amazing. I think
losing hair.
I lost most of it.
Yeah.
I think we've got this offer running right now for unlimited treatment plans for 6 months or 1 year. And I think we learned this from you and Dr. Randy Resnik, is that when you said like the road to a predictable outcome or predictable results starts with a proper plan. So that's why we would like to offer everyone out there treatment plans. Even if they're not getting a surgical guide, please get a treatment plan so you can properly present the case to the patient and properly draw a blueprint for the whole case. So that's why we have these 2 offers running, one that is 6 months unlimited treatment plans for $3,999 and 12 months plus this new surgical kit for $8,000. Again, covered for the whole year. You can get as many treatment plans as you would like to. I've got a bunch of questions here for you, Chris. I'll start with I mean, you answered this somehow in your presentation, but do patients have better outcomes with RP4s or RP5s?
Yeah, I find that, it's a great question. And I think it goes back to patient education. If you educate the patient prior to going into treatment, what they're receiving, both are going to be highly successful. Where you get into issues is where you're delivering that patient a 2 implant overdenture and they think they're going to have a fixed prosthesis. So, as I mentioned, somebody with an upper denture and 2 implant overdenture, they're not going to be eating a steak. Whereas somebody, if you put, 6 implants on the lower and make them an overdenture, that's functioning as a fixed prosthesis. They're going to have a lot more budding force chewing efficiency there. So I think both are equally as successful when done on the correct patient, as well as with the correct patient education and expectations.
Gotcha. The other question that I have for you is, if someone have problems with hater clips, when it's being picked up in the mouth, they often cannot get them seated.
Yeah. Yes. Yeah. So hater clips, we still use them a lot. They're a great attachment, very low profile attachment on the bar. They're made for a hinge movement, so it's a resilient attachment that hinges. But like the locator, you want to use their pickup housing. So they have a green pickup housing that when you're picking up the denture, you want to use that to pick it up and then transfer them to either the yellow or the red there. So similar to a locator, when you're picking up a locator, you don't want to use the blue, the red, you want to use the black to pick it up, and then you can transfer them or transition them into a colored male attachment.
Gotcha. Another one here. How do you feel about the locator RTX? Is it better than the original one?
Yeah, so that's a great question there. That's one of their new being. It's been out for a couple years, but it's the exact same thing as the locator, made of a different material. It's like a pinkish material that they say is more wear resistant. With it, you also supposedly get more retention and you have more angle correction. I've done a couple cases. I have not found that to be any superior than the locator. To me, the biggest issue is you have thousands of patients out there in the traditional locator attachment. And then if you're going to transition to the other locator, you have to get all new parts because those have different male attachments. So it just kind of increases the amount of material that you need in the office. And to me, I haven't seen that big of a difference in patient outcome.
Okay, gotcha. Well, I'll read the next question the way it is. I have a lower 2 implant over denture, tried every color locator, still do not have enough retention. What do I do?
Yeah, and that happens a lot. So you keep bumping them up to the next and you're still not getting the retention. First thing I'm gonna look at there is the soft tissue support. So you're going to see if they need a reline. The majority of the time they would benefit from a reline. So that's where, a quick, cheap way to do it is put some green stick compound in there and see what that does to the retention. The next part of the laundry list there that I'm to look at is look at their locator attachment. Generally it's going to be worn or there's going to be food in it there. So if it's worn, talking about making a new locator or new locator abutment, there's food, get the food out. But generally those are going to be kind of the top two reasons there, but it's a very common problem.
Gotcha. Another one, I'll read it the way it is. I have a patient with 2 lower anterior implants. The patient came in with no posterior occlusion. Why does this happen?
Yeah, so that goes back to the reline there. So with a 2 implant overdenture, it's going to move posteriorly there. So what's happened is that patient's most likely not been seen for a while, and she's continued to chew in the back and actually lost bone in the posterior there. So the bones resorbed there, leaving her with that occlusion. So the way you fix it would be with a reline.
Gotcha. Someone completed a 4 implant overdenture, and it's against an upper denture. The patient now complains about the upper denture being too loose. What to be done here?
Yes, that's also a common problem there where, they come in with dentures, you make them a overdenture and now their upper denture gets loose there. So that is one of the things that we do tell patients prior to going through with implant therapy, whether it's an overdenture or a fixed prosthesis. But for that case, what I would look at would be the type of occlusion pattern. You want them in medial lingualized occlusion. That way the lingual cusp on the upper is coming straight down into the lower. That will help correct it. A reline will also help correct it there. But that is a common problem where you upgrade them on one arch and then that other arch goes backwards.
Well, this was amazing. I think I'm done with all the questions over here. Again, Chris, thank you so much for this amazing presentation. And I would like to extend my thanks to the panel, Robert, Milad, Sarah Amin, Dr. Robinette, Hussein Tariq, Dr. Sheehan, and of course, Tara Resnik. The recording for this webinar, as well as the previous one and the next 2, when they're done, would all be on our page on YouTube. The CE credit will be emailed to everyone who attended this, attended the webinar today. And with that, I would like to thank everyone. Again, thank you so much, Chris. And thank you, everyone. Thank you for taking the time to attend this webinar.
Awesome. Thanks.